It went well, sir. Good. I talked about सब कुछ. Yes.
Crossing the last day.
Okay, so
can you turn? We can't hear you, so can you turn the mic on, please?
Turn on their mic.
Mic on it and then. Technology हमेशा धोखा दे देती है आपको. Right, so
Yeah, if you could turn on your video and mic, please.
Can we turn off the barrier?
Display कर दी बात है?
इसी में रहने में निकालना सब कुछ निकालना निकालना पेसिंग वायर सारा कुछ ठीक है इंशाल्लाह.
Numan, we are hearing all your conversations, so turn off your mics, maybe.
Okay, so actually that's good.
Şanlı göremiyorum hocam. Bir dakika.
So we can see the screen, but it's not moving. It's not playing yet.
Ben şey göremiyorum. Dur hocam.
So can you please turn on your mic as well as your camera? Can you turn it on? Because what we're seeing is just a fixed picture. We're not seeing, nothing is moving on the screen, and we can't hear you. He's on the phone.
Might have to do screen share. He has to do screen share.
So while we're waiting, what percentage of patients are same-day discharge now for you guys in the US?
I think it's still a minority in most of the places, at least in our market here in Orlando. It's usually next day discharge. We did same day discharge during COVID just because of the issues with the hospital bed pressures.
I haven't sent any home the same day, just because I haven't. I think the discussion about cost saving and stuff is all fair. I've just not had the courage to do that yet.
Hello, everyone. From Memorial Hospital, we are doing.
So, any one of you using single closure device versus two?
Yes, you can do one per close and get away with it. Just be prepared to add an angiocelate French later if needed.
We usually go 2 per closes, Bashir.
Usman, are you using one or two?
We're using 2 so far, but it's...
Yeah, we have tried using one again to save the cost, because over here the cost becomes the major issue. It's like almost 60,000. So.
Yeah, we are re-sterilizing our Confida wires.
Yeah, that's what we are doing too. We are doing the same.
Yeah, so it might be worthwhile now to do just 1 per close, because the per close cost is more than doubled, I think. So so that's becoming a big factor.
The other comment for crossing the valve is be prepared to use a .018 or other .014 wire. A peripheral wire can work sometimes. Straight glide is very useful. If you go with an aggressive guide, you may run into other issues. You do need some support, but the key is, be prepared to use a peripheral wire.
And for echo follow-up, you guys get pre-discharge echo, or is it just 1 month and 1 year, 1 month, 6 months, and 1 year? I think it's in the US. How do you do?
Osman, they have to change the screen now. We have a screen.
And 2 years ago, patients had RCA graft PCI, but after PCI, Safan graft PCI, stand up next please, and then we found the 0.5. You see that how tortuous is it? Okay.
Okay, great. So we can see it.
Okay. So I dilated it, and I will introduce two, right? I am pushing until we have, now I have a bleeding here. As you see, I have a bleeding. The first pergolide, copy.
We had better move a little bit. This is a perclose insertion. Yeah, we can. He will do it. He will do it. Yeah. Go faster, Hashim. Little bit, yeah. Biraz daha ilerlesene. İlerle buralara. İlerle. İlerleyebiliyor musun? İlerle. Kapağı da geçelim. Ondan sonrasında işte
I don't use diagnostic LA, but I use guiding LA. The reason is
sometimes, if it is difficult to cross the aortic valve, sometimes I use pigtail. Pigtail also, diagnostic pigtail also may help to cross valve actually. Hashim, can you a little bit move on?
Is that a JR4 guide that you're crossing with there? That's a pigtail. You're crossing with the...
it has to look LVOT, which is okay. And now I'm ready. Then we may have less post-dilatation. Coronary sinus, but it's okay. Let's do predilatation and then inflation.
So the most important thing for accurate, I should tell you that you have to have a nice predilatation, right? So we have to have a prepared nice space for valve. This is important. Yeah, we do nice predilatation, almost 1-to-1 size for accurate.
So this is the deepest place we could go with pigtail in the coronary, non-coronary sinus. So we should accept this, and then now I will in the future. So we have to be
one step,
easy.
so you don't have to swap it
Because
out. The pigtail goes in.
Yeah.
Take some practice.
Okay.
Now we are inserting valve.
Umar, how would the pigtail help in crossing the valve? You said you use pigtail.
Yes. You know, if it is difficult to cross LA1 or right junctions, you try everything.
Has to be
you can use pigtail, not to cross with the pigtail. You use as a catheter. Of course, you have to have your wire straight. So pigtail gives you chance to go different place. You cannot have with LA1 or right junctions. Of course, wire has to be straight, right? So, but then you can face different place of the valve.
Most of the time we lose our pigtail position while we inserting the our valve.
Most of the time when you insert the valve, pigtail position changed, right? So What we, what most of the time what we have to do, we have to remove it a little bit proximally and engage the, so place it again most of the time, because when you insert valve, pigtail most of the time change place.
So the interesting thing about Neo 2 is that the upper portion deploys first, and then the annular portion deploys.
Yeah.
And
Now
that,
we have
another important issue to have better commissary alignment. We have free cell in both sides, and we have two free cell, and each free cell has to be on the left side and the right side. So we have to see both of them in one plane.
And also we
here
have
now,
a marker, you see the marker?
cell,
That marker has to be, lower edge of the pigtail.
and the pigtail for this is in the non-coronary cusp.
Yes, yes.
And you use the cusp overlap view or three cusp view for your valve positioning?
Yeah. In here, most of the I use cusp overlap in here also, but I think it's helped to us because we have done see the long axis with cusp overlap.
And so you mentioned that you need a good pre-BAV. What are the reasons that you need a one-to-one BAV? Because that does increase your chances of having significant AI, and you may have to rush through your valve
Definitely,
deployment.
yes. Both valve expand well if we have nice pre-dilatation, and secondly, we have less post-dilatation need. So.
So, Umar, what is the radial strength of this valve as compared to the Medtronic valve?
What we see in our practice is a little less than Medtronic valve in terms of radial force. They say that they are the same, but in my practice, I would say that a little less. That's why we have to prepare valve better than Medtronic valve.
Okay.
Haşim bir daha şey yap istersen videoyu.
Tamam hocam, daha yükleyeyim.
Kapatıp bir daha aç da.
In the US, are you using still for Sapien the three cusp view, or have you tried cusp overlap view for valve positioning for Sapiens?
Three cusp view, coplanar view.
Yeah, the three cusp view.
I think there was some data, I don't know if Abdul Hakim is here, but he'd mentioned that there was some data that pacemaker rates with Sapien go down even further when you use the cusp overlap view.
Basically, cusp overlap shows us long axis rather than short axis. So I think it's more.
That is true. There is some data to that.
Issue.
So let me give you my spiel on crossing the aortic valve while he's getting in there. So when I go in, start with AL1, and that works about 70% of the time. Do an aortogram before I try to cross it, and I'm wanting to look at a view where I can actually see the central hole, and also look at the size of the annulus. So when I put in AL1, if it is too small, then it's not going to go to that hole. So you're going to go a step up to AL2, obviously after you try the L1. If the angle is really horizontal, you're going to use a JR4. If the angle, that is the aorta to the LV, is very vertical, then I use the multi-purpose. So those are the 4 catheters that end up being used. And it's really not the force, because you're wanting to try to go in slowly and meticulously. It never needs any force. It's just straight in, and it goes in like almost like a butter. If you hit the right spot, it just goes in very easily.
Thank you.
almost never have to use any other wire. It's just having the right catheter. If you take a 5-French catheter, then you're going to have some interplay or resistance between the wire and the catheter. And that's why folks have suggested using a guider. My problem with a guide catheter is that if you're in there for a longer period, it becomes really soft and doesn't hold its shape. So just a 6-French diagnostic has a thicker wall and holds its shape a little longer.
Thank you for those comments. I think, Dr. Omar, the file is not playing, so we're going to move on to the next session, portion of our session. So I see Dr. Tahir Saghir, Dr. Abdul Hakim, Dr. Naveedullah, Dr. Mohammed Waleed, and Dr. Asad Bukti. If you could come up onto the podium. I think Dr. Bashir is here. He was at Dr. Asad Pathan. So our next case presentation is a very exciting case from NICVD. This is our second case. So we'll request the presenter to come on and go. All right, over to Dr. Tahir Saghir.
Okay, thank you. Good morning, Assalamu alaikum. This case of Basilica we did 2-3 months before. Next slide. It's a 79-year-old lady having a bioprosthetic valve in 2012. The make of the valve, we didn't get it, but we have access to the surgeon, and he told us that it was a sand jute valve that was made in, I think, in Brazil, a bovine valve, because porcine valve was available at that time, so a bovine valve was made for this case, and it was implanted in 2012. Patient is in function class 3-4. She had a non-obstructive coronary arteries. At the time of presentation for the last 2 months, her echo revealed severe aortic incompetence. Her STS score is 5.1 and Euro score is 12.9. We had a heart team meeting, and in heart team it was decided that we should go for a valve-in-valve. She had a preserved LV function with severe AI, moderate AS with mean gradient of 27. Pulmonary artery systolic pressure was 60. And surgical aortic valve internal dimension was almost 18 millimeter. She was in sinus rhythm with interventricular cardiac defects. She had hemoglobin of around 10, and she had deranged renal function with creatinine clearance of 22 ml. Hemoglobin A1C within normal limits, TLC is normal. She is well-built lady. On CT, her access site was adequate, almost 7 to 8 millimeter. When we see the things in CT, her valve to coronary distance was on the left coronary system was almost 3 millimeter. The right was adequate, and the height of the cusp was adequate in the right coronary artery. But in the left coronary artery, it's almost 15 millimeter. The coronary height was also almost 7 millimeter in the left coronary cusp. So we plan to go for a Basilica in this case. Next. These are the echo images. You can see severe AI and the cusp excursion. Previous में आ जाएंगे. Run कर देंगे. You can appreciate the cusp is escorting and just obstructing the left main. Next. So as a procedure, we made a very short presentation. In procedure, we put a I think it was a multi-purpose catheter. No, it was a AL catheter that was straightened down because we have problem with the inventory. And we have a snare, her LV outflow was 22 and the snare is 20. Snare of 20 mm. Then with the 7 French EBU, we have a dual access, 7 French EBU. We have a child and mother catheter, that is the AL, and we try to locate the cusp, left cusp, behind the valve cusp to puncture the valve. Next. So we puncture the valve and then we snare this wire. Next. Let me tell you that we have a problem with the inventory. We don't have a stato wire. We asked our colleagues, but it was not available in 2 or 3 centers. So we, So we go with the Conquest Pro 12 and we use this technique of a cautery that we use this wire to puncture the lower part of the left cusp, behind the left cusp, and puncture it straight down into the LV. And then we snare it, and after snaring, we tried multiple 2 to 3 wires with a V flying we made, and when we try for this cautery, we didn't get that adequate result. Then we go with a 5015 an NC balloon, and we inflate that in the cusp. And then next. And then in this view, you can see we pull from both of the catheters and we tear the left cusp of the prosthetic valve. And you can appreciate in the echo that the AI was there, but the flow to the left main is now improved. Next. Then we place a protection in the left coronary system with a guide liner and a 2O balloon, and then we go with our usual procedure for the implantation of a 23 millimeter evolute R. Next. Next. We intentionally put a little bit lower down. Next. And after implantation, we see that the left main is patent and the left system is adequate. We just leave the guide liner there, and then we put another GL catheter and do a selective shot. Next. These are the echoes. You can see that the AI is much improved. And LV, as usual, it's preserved. Next. This is the case we did. And after the case, we had improved LV with the reduction in the AI, and the hemodynamic parameters are okay. The case is open for discussion. With me, Professor Abdul Hakim was there, and we both, along with our TAVI team, did this case. Dr. Hakim. Dr. Kim, can you have any comments?
So I think there were unique challenges. If you look at the CT scan, the sinuses are 22 and a half, and the smallest valve we have is a 23. So regardless of what you do, if you are to, there's another procedure called a cathedral. Cathedral is different than basilica in that you capture the leaflets, you snare all the way to the base, and you burn, and you essentially pull those leaflets out. So if he had done cathedral on all 3 leaflets and taken them out, there would still be sinus sequestration because there's no room. The sinuses are so small, they're 22, and you're putting in a 23 frame. Unless you deploy the valve all the way in the mid-ventricle, you're not going to get to 20 millimeters because the waist of a 23 valve is 20. And if you want the waist to be at where the coronaries come off, you really have to deploy the valve all the way beyond the LVOT. So here we aimed for a 6 to 8 millimeter. It was intentional. Unfortunately, the issue we had, now doing a basilica has become really, really easy. Going back, I remember the first couple we did, and actually we did it how it was done in the initial experience. So in the initial experience, there was no electrocautery. You had to take a wire, literally a spear, and puncture through the left coronary leaflet, and then snare that, and then make a flying V, and then use brute force, just like we did in this case. We had to use brute force to pull it back because we really did not have the right wire. So why is Estato the preferred wire? Well, Estato is a preferred wire because it can conduct and burn through any part along its length. This was an urgent case. It was a patient of Dr. Tahir Saghir. She had class 4 symptoms, and she had wide open AI. And one thing that wasn't mentioned was she had a prolapse of the left coronary leaflet. So if you think mechanistically, a prolapsed left coronary leaflet is a leaflet that's already torn. Why would a surgical leaflet prolapse? It's a leaflet that is already torn. So you never know how this leaflet is going to behave, which is why one may argue, you've already done a basilica, why are you wasting inventory? Why are you putting a guideliner? Why are you putting a balloon? Because like I said, even if you do basilica, even if you do cathedral, the concern of coronary obstruction is still going to persist because there's no room. There is really, really no room. So initially the concept was to put a guideliner, and once we did a guideliner, then we put another guide and took a picture, and we were like, okay, if there is compromise, we would do an orthotopic snorkel stent to do that. Now, a couple of things about basilica which are very, very important. Ideally, you want to have a AL2 guide, because an AL2 guide really points you towards the nadir of the cusp. Understand that it's very difficult.
And so, are you using 3DT? Because you had a TE probe down there. So
well, TE doesn't help, Usman Bhai. I will tell you, it's very difficult to gauge on TE, even in the US when we had the best equipment to do 3. But in this case, we were not using a 3D probe. What it does ascertain for you is you are in the left coronary cusp. Beyond that, you can't tell if you're at the side. The idea is to be at the nadir. Yeah. And the way you ascertain that is you go in the LAO cranial view. So in the LAO cranial view, you have the left main, you have the cusp. So you want to make sure it's pointing. And then you come to the RAO caudal. So it's just like when you do a mitral clip and you switch between the LVOT view, 120 degree, and the BICOM view to see how medial and lateral you are. So if you were to use that analogy, RAO caudal is your BICOM view. You want to make sure you're right in the center. The problem is, as you can imagine, if you think you're in the center and you burn, you could go anywhere. You can puncture back into the septum, you can come out of the heart, depending on where you puncture. In most cases, it's very forgiving because it's just a 014 wire that you're using, but it doesn't look good because you see this color flow that is going at odd places. So I think that is the most critical piece, and that is probably the most time-consuming aspect of the procedure, is to see exactly where you puncture. And then after that, okay, now here, balloon-assisted basilica is something new. This was done, it was already pre-planned. So what is the concept in doing a balloon-assisted basilica? So if you inflate a balloon, now you know you've made a hole. When you burn, you're literally making a fillet. You're just cutting in a straight line. But now if you make a hole and then you cut, that gives you an added sense of reassurance. It's all theoretical, so you could argue, well, that's all baloney. But we've seen that if you do balloon-assisted basilica, that is, now this patient already had AI. The problem happens when the patient has AS.
Right.
If you're doing a basilica on an AS patient, that's a different animal. Because the moment you do basilica, they're going to wide open AI, patient goes into shock, codes on the table, then you don't have time. And it's AS, you have to, so in doing a basilica in an AS patient, you almost always have to leave a protection wire in the LV.
And can you talk a little bit about how you, when you're doing the cautery, you cover most of the wire except the area that is doing the cautery so that you don't burn elsewhere?
Yeah, so in the US, there's a catheter that we used to use called a piggy bag. A piggy bag is specifically designed for this, right? Here, we didn't have an AL2 catheter, so forget about piggy bag. So what we had to use was I think we used a fine cross, sir. हमने fine cross use किया था. So we used a fine cross catheter, the idea is, so if you think of it mechanistically, what you're going to use is, in this case, first we use a Confianza Pro, we punctured, we snared it, we took the fine cross into our multi-purpose guide, which had the snare, then you switched it over to a 300 centimeter wire, because we didn't have a Stato. So before you introduce that, right at the point where you have the wire gets externalized, you're going to make a V inside with your scalpel back end of it, and you're going to denude only the inner side of it, not the outer side. Because if you do the outer side, you could be burning the wall of the aorta, like Usman Bhai just said. You could induce a dissection and whatnot. So it has to be on the inner surface. In this case, really, we did not have the cautery work. We switched 3 different wires in the hopes of burning it. And finally, it was like 2 hours. So it's like, okay, let's do it the old-fashioned way. And it was just brute force to just cut through that. And because the patient already had wide open AI, she tolerated that 3 or 4 minutes fairly well. So one question I have for you, Usman, what do you do with your patient that you do a valve and valve TAVR in? What's your anticoagulation regimen? Do you put them on anticoagulation for life, or do you still do dual antiplatelet or single antiplatelet?
You know, we've generally done dual antiplatelet. I know there's some data out there that suggests that a period of anticoagulation might be helpful because of the amount of tissue that's left in there, but we're currently just doing dual antiplatelet therapy.
Okay, so I think the way I practiced, I think for valve and valve specifically, I think giving anticoagulation, a DOAC, it doesn't have to be Coumadin, unless somebody has. So I think giving DOACs is, I can't quote you the paper right now, but I think giving DOACs after a valve and valve, because obviously you can see now, in this case, one could argue, well, you had an 18 ID, and now you've put a 23 supravalvular platform. Thankfully, gradients weren't too high. Is this something we could fracture? Absolutely not. There's no room over there. Yeah. So, but if you are to fracture, you try to increase your effective orifice area, right? So these valves are already constructed. So the concept is, and plus there's also a theoretical risk of increased halt if you do valve and valve procedures.
And so it's also important to realize that if these patients go for a redo surgical AVR, there's still a risk for left main obstruction because of surrounding edema. The coronary height is quite low, and so at times they may have to reimplant the coronary because they don't have enough room, and there's a lot of scar tissue from the previous valve, and you can post-op edema can cause some degree of coronary obstruction. So a redo surgical procedure also runs similar risks and challenges.
very nice case. I congratulate NICVD team for doing this complex balloon-assisted Basilica first time in Pakistan. I want to ask one thing, the coronary eccentricity, does this has any role before doing the Basilica? Do you consider that thing, where to lacerate the cusp if you find that the coronary ostium is eccentric instead of at the nadir?
See, you're asking me a very technical question, and I'll be very honest. Like I said, the only thing that has been established for Basilica is you want to aim for the mid and the nadir of your cusp that you want to lacerate. Could you go sideways? It's incredibly difficult to do. Like I said, even establishing the nadir of the cusp, you have to rely on two views. Can it be done? Maybe you get a catheter that can map out the cusp for you, and then you can go 20 degrees northeast versus 10 degrees southwest. But I think our understanding isn't that, at least myself, my understanding is you want to aim really. Could you go sideways? That would carry a lot of risk. If I go sideways, I puncture, say, into a structure and a patient goes into tamponade, what's my bailout? There's no bailout.
Yeah. Well, thank you for a fantastic case and great learning, and congratulations on helping your patient with these techniques. So we're going to try again to see that NEO2 deployment. So can we go back to the feed from Turkey, please? So yeah, if you could expand that Zoom window, and we'll just take a few minutes to see that NEO2 deployment. I think we got the technical challenges sorted out. Could we get volume? We can't hear the narration. So can you unmute them, please?
Okay, let's have another injection.
So NEO2 is a top-down deployment. So
position is good. I remove my pigtail, and then quickly we will open the second knob. Okay, open it, please. Yeah. Okay, wonderful. Okay. So we deployed the valve. Let's remove the nose first, carefully. So in that case, I will remove wire a little bit back, and then try to centralize my nose. So we have a 2-to-1 block, and we need pacing. Let's do pace. All right. So we will now, again, we have to close the valve here. The first two. We have to close the valve again, and first we do number 2. And then number 1. All right, and we can remove valve now. Please, can you remove it? So let's have pigtail. Okay, let's do injection here. I think the result is acceptable, and I don't think we have to do another post-dilatation right now. So I will change my wire, software wire, to pigtail, and then we will do echo measurement. Now I think this result is acceptable. What I do now, I will change my software wire with the pigtail to measure gradient, and also to check if you have any regurgitation. And also, after inserting pigtail, my colleague will do echo evaluation, and we will share with you. So, Özge, could you tell us what we have after valve implantation? How much the gradient, and if we have any leak?
Yes, I don't see it primary patient. Here, again, Florence,
another injection. see. Okay, I think the result is perfect. We have maybe mild AR, nothing more. Thanks to Accurate, because they have now parallel leak seal technique, and they extended skirt up to the crown. I think it helps us a lot. You know, after I use, so far, I don't have any mild to moderate AR. So I'm very happy about the result.
Great. So I think
in gradient, please show us the pressure.
So I think we'll
now we have, as you see, we don't have any gradients after one.
So in the interest of time, we'll move on to our next session, but a great demonstration of Neo 2. It's a good valve available, I believe now in Pakistan, although it hasn't been used yet. Dr. Tahir Saghir, you had a comment.
Can I have a question? It's an excellent case of Neo 2. Can I have a question with Umar Godkin? As this valve is partially Edward type and partially of evolute type, the make is like that. Can it be retrieved or not, recaptured or not, or is it a single way?
No, we can't retrieve it. It's one shot. One shot. Okay. So we don't have any chance to retrieve it. Yes. But since you know it's not difficult to embolize it, you know, after deployment, I mean during deployment. So it's really user friendly to me. Okay. I would say, yeah, you can precisely implant the valve. Okay. Now with Accurate Neo Kit, they have a marker, which is I think it's very helpful to place the valve. I think we have very low risk to embolization.
Okay. Thank you.
And I think, correct me if I'm wrong, but since it's a top-down deployment, you can deploy the upper part of the valve, which becomes functional, and you can reposition it to where you like it. And then the second stage deployment is very rapid.
Yes. I mean, before deployment, you can adjust it, either pull or push or pull. Yes, yeah. Exactly.
Yeah. Great. Well, thank you very much for a great case demonstration. And with that, we'll move on to our next session.
And finally, we come to the closing ceremony of the Pakistan Live. That has been a success, like always. It was attended very enthusiastically, as on-site as well as online. And regarding the closing ceremony, this has been a hallmark of the conference. Fellows Case Corner has been one of the great attractions of this conference. Each year we get a number of online submissions. For this session, I would call upon the newly elected council of PSIC to be on the stage. So in the increasing order, the Treasurer of Pakistan Society of Interventional Cardiology, Dr. Jabbar Ali, please. Dr. Jabbar, and the Journal Editor, Professor Tariq Ashraf Sahab. Is he here, Professor Tariq Ashraf Sahab? Okay. So the new Joint Secretary of the Society, Dr. Suhail Azimi, please. And the General Secretary of the Society, Professor Tahir Saghir Sahab. Vice President of the Society, Professor Noman Nasir Sahab. Is he around? Noman Nasir Sahab. Past President, Professor Nadeem Rizvi Sahab. President-elect, Suhail Aziz Sahab. And one of the course directors, Professor Bashir Hanif Sahab. Bashir Sahab. And the new and current President of the Society, Professor Zubair Akram. Bashir Sahab, Zubair Sahab, please. And we are thankful for the online panelists. Dr. Naeem Tahir Khili is online with us, and Wasif Qureshi Sahab is online. You guys can stay, we are very thankful to you, and you can stick around during the closing ceremony. We will be grateful. So coming back to the Fellows Case Corners. This time we got 108 online submissions, and after screening, we were left with 88 eligible cases. And these cases were made anonymous.
Sorry to interrupt. I just wanted to say that the online panelists have been sitting there since morning, and if they are more than welcome to stay, but if they have to leave, they can. And I'm grateful to Dr. Wasif Qureshi, Dr. Naeem Tahir Khili, and Dr. Tahir. Thanks a lot. Really appreciate it. It's up to you. If you want to stay, you're more than welcome. Sorry.
Thank you. So all these cases were made anonymous and then sent to the reviewer in a blinded manner. There were a panel of 36 reviewers. Most of them were from abroad, and few were senior reviewers from Pakistan. And this time we revamped our scoring system and made it more objective. Each cases was marked on these 8 criteria, and out of total marks of 65. And then we had an aggregate of scores from 2 reviewers for each case. By that we selected the top 27 scoring cases, which were presented in this Pakistan Live on the 28th and 29th of April in Hall B. And then the 4 best were selected by a panel of experts. And these are the 4 best cases. One of them is by Dr. Ali Farahe. He's from AFIC, and he submitted a case challenging TAVR case. Another case is by Dr. Usman Zia from Faisalabad Institute of Cardiology, a novel case of pseudoaneurysm. Dr. Jalal Khan from PIC submitted Less is More or Face the Music. And Wasim Khan from LRA Peshawar submitted Out of the Frying Pan. So we will request them to present these cases in very short manner, just over 3 to 4 minutes, to just to have a taste of what is the top quality of cases that we are getting. And then we will announce which of these cases were number 1, number 2, number 3, and number 4.
Can I suggest, you can go with in reverse order, I think. Or random? Okay.
Okay, these are being presented randomly, and we will announce the best cases.
So we
best
see
among them, best
random
among them.
and final decision at the end. Thank you.
So, in this order, I would request Dr. Ali Farahe to come up and present his case. Dr. Ali Farahe from AFIC.
Bismillahirrahmanirrahim. My name is Dr. Ali Fareh, and I'm a fellow in intervention cardiology at AFIC, NIHD Rawalpindi. And to begin with, I would just say that it's such an honor to be in the presence of such esteemed local and international faculty. I'm going to discuss the challenging TAVR case. I will begin with case summary. We had an elderly, moderately frail male who had low body mass index. He had very severe symptomatic aortic stenosis with reduced EF, and he presented to us with LVF and acute coronary syndrome. He only had moderate LAD disease. Rest of the vessels were quite normal. Due to these factors, he was intermediate to high risk for surgical AVR, and he was surgically turned down. His TAVI workup was done, and his vascular and valvular anatomy was quite conducive for transfemoral TAVI. So heart team meeting was convened, and it was decided to proceed with a size 29 self-expanded evolute device through transfemoral route. So we had quite a remarkable procedure, and this is the second last picture of this patient. And as you can see that we have well-positioned, quite highly deployed TAVR device, and there is good expansion, and also there is like minimal to mild AR. So this was the assumed final picture, and this happened just 30 seconds before the patient collapsed. So as you can see, even in this picture, there is some dye staining the aorta. So how we reached there, I will give you a just brief procedural overview. So this was the final valve deployment. As is the norm at our center, we finished the valve deployment in the coplanar view. As you can see, the lower portion of the valve is quite underexpanded. Nose cone was removed. Due to an expansion, we actually decided to proceed with post-dilation using a wax 26 size balloon. And you can see it resulted in good expansion. So this was the picture. And immediately after post-dilation, patient crashed. His BP fell from 120 to 40-20. He had an episode of ventricular fibrillation, and ACLS CPR protocol was actually started. Luckily, we had anesthesia team at hand, and they took care of the CPR part of the procedure. So what had happened? These were the 4 possibilities we thought at that time. First was the annular rupture leading to the tamponade. Second was the coronary obstruction leading to acute MI. Third was torrential AR. At this stage, with sheath still inside the patient, the bleeding complication leading to such a rapid deterioration were less likely. So clues to the etiology. We had T-probe in. It showed some fluid around the heart, but it was pleural fluid and not pericardial fluid. There was global hypokinesia, and EF has actually fallen from 35 to 15%. And there was mild to moderate TR, but not something that would have led to this such deterioration. There was ECG leads present, and it showed generalized ST depression with elevation of AVR. So this led us to suspect LMS obstruction. So during CPR, we proceeded with, from already present left femoral side, we took a JL guide, and this was the first shot. As you can well see that there is only a trickle of blood into the LMS. So we tried to wire LAD, but wire went toward circ. So during CPR, we just wired the circ. We pre-dilated the LMS ostium first with a 2O balloon and then a 3O balloon. And all this was done during the CPR. So the next problem was that we could not cross the stent. We took a 3.532 stent, and it could not just cross into the circ. So next, we took a guide liner. We took it to the mouth of the LMS ostium using balloon anchoring inside the circ. And luckily, with the help of this guide liner, we were able to cross the stent into the circ. The stent was deployed with 2 mm hang into the aorta, and eventually we had some flow into the left system. Port was done with 4O balloon, and after these interventions, we were able to get good flow into the circ and also into the LAD. So after 30 minutes of the CPR, patient had resumption of spontaneous circulation. His pressure jumped to 70/30. He was shifted to the coronary care unit, ICU unit. He was weaned off from the inotropes in 12 hours. And he was discharged on 4th post-procedure day. And his EF has actually jumped up to 55 to 60%. And this is his final pre-discharge echo. And there was only minimal gradient across the aortic valve. So what had happened? Basically, this was the leaflet. As you can see, the leaflet is quite bulky. And there is also topmost portion where there is some calcified nodule. This possibly partially obscured the LMS ostium, which led to this problem. So you can see during post-dilation, this calcified black portion jumping up toward LMS. So just give you a short overview of what had happened. These green colors are basically the leaflets. We had deployed the TAVR device. There was some under expansion. And then we went with the wax balloon for post-dilation. With this balloon, we were able to post-dilate it. However, it also resulted in the lifting up of the leaflet toward the LMS. So there was ostial pinch of the LMS. We took a left guide. We were able to wire down the circ, and then we pre-dilated this ostial lesion. The stent could not cross. So what we did was we took a guide liner, and with the help of the anchoring technique, we were able to place it at the LMS ostium, and finally we were able to deploy a stent here. So this was basically a short animation showing the summary of this case. Thank you.
Thank you, Dr. Ali. So for next presentation, I would request Dr. Osman Zia to come up to the stage and present his case. He will present a case of novel case of pseudoaneurysm and how did they manage it.
Hello, Assalamu alaikum. My name is Dr. Mohammad Usman Zia. I'm an FCPS pediatric medicine. I'm doing a fellowship in pediatric cardiology, and I'm representing Faisalabad Institute of Cardiology. I'm for Faisalabad. Today I'm here to present a novel. Today I'm here to present a novel case of pseudoaneurysm. What is a pseudoaneurysm? Pseudoaneurysm is a false aneurysm which involves the outer layer of arterial wall, which is tunica adventitia. So here I'm going to present a case of a 36-year-old young man which presented into the pediatric cardiology OPD with history of swelling in front of chest. For last 4 months, the size of swelling was increasing, and there was signs of discomfort and progressive discomfort and dysphagia for last 2 months. That was progressively worsening. On history, when a history was taken, there was history of aortic valve replacement 18 months ago, and when further history was probed, the patient was reopened on the same night due to hematoma formation, and the hematoma was drained, and a patient was recannulated, obviously, and went to the cardiopulmonary bypass on that evening, and RV puncture was found, and it was repaired with an RV patch. Here's a video showing a mid-sternotomy scar along with there is a pulsatile swelling in front of chest. So we went for septic screen of the patient, which came out to be normal. ECG was normal. Chest X-ray was done, which showed a mediastinal widening. As you can see, there is metallic aortic valve is also being showed here. So we went for echocardiographic. Here is a video of normal functioning aortic metallic valve, and there is a outpouching. There is a cavity in front of ascending aorta, and high up in the ascent, which measures about 11 into 11 centimeter, and high up in the ascending aorta there is a rent. A filling defect was found which was communicating with the cavity. So here we went for CT chest with contrast, which showed this is a aneurysm, which showed aneurysm. I'm going to read the report. There is a large pseudoaneurysm arising from left internal memory artery, which measures about 9.8 to 8.5 centimeter, and which is partially thrombosed and causing compression of the anterior mediastinum. Astonishingly, it was quite contradicting with our echocardiographic findings. In echocardiography, we saw that the aneurysm was communicating with ascending aorta, but here it is communicating with lima. So we went for conventional angiography. Left internal memory artery and right internal memory artery were catheterized, and angiograms were performed. We came out to be normal. Then we performed aortogram high up in the arch, which showed a rent, a large rent, which measures about 4.87 centimeter, which was communicating with an outpouching in the anterior mediastinum. So we went for, involved a multidisciplinary approach, and we involved the pediatric cardiology, adult cardiologist, cardiac surgeon, and a team in our cath lab, and we decided to go for device closure of this patient. we selected a LifeTech Conor multifunctional device occluder. According to the size, it was 5.03 millimeter, 2 to 3 millimeter. We took the size bigger than the rent. We went for LTMFO 10.8 device. It is low profile device and takes a softer flexible sheath, as the wall of pseudoaneurysm is quite so we crossed the aneurysm with the glide wire, Terumo glide wire, and angiogram was performed with 5-French GR4, which showed a swirling of blood, as you can see in the pseudoaneurysm. So the pseudoaneurysm was punctured entirely from the chest, as you can see, and an angiogram was performed, and a wire and sheath were placed interiorly from the chest, and so aneurysm was aneurysm excess was taken from there. Next one. Then we parked the glide wire into the pseudoaneurysm, and over the glide wire we selected a 5-French delivery sheath or long sheath, over which we are going to through which we are going to pass our device. So through the delivery sheath we passed our LTMFO 810 device, and we opened the distal disc. The whole assembly was taken back and check angiogram was done. Then the proximal disc was open, and angiogram was done entirely from the sheath which we have placed from anterior chest. After that, the aortogram was done to see whether there is an obstruction of innominate artery or not. So the device was successfully opened, and this is a post-procedural echocardiography of this patient, which shows the device here. There is no to and fro movement across the device. This is 1 week. After 1 week echo we performed, which shows a clot formation here, and there is no movement, to and fro movement of blood across the device. This is pre and post procedural X-ray of the patient. You can clearly see there is a mediastinal widening, while after procedure clearly the mediastinal widening has been resolved. And this is the picture of of anterior chest. As you can see, the pulsating mass has also disappeared in this patient. Thank you very much.
Thank you, Dr. Usman, and well done, the team of Faisalabad Institute of Cardiology. Next up is Dr. Jalal from Punjab Institute of Cardiology, Lahore.
Bismillahirrahmanirrahim. My name is Dr. Jalal, I'm PGR in Punjab Institute of Cardiology. Respected seniors, dear colleagues, respected chief guests. Here we have see these three dots over here, and we have something which comes in our mind. The first question is what these three dots actually determine. So we have to see that a patient, 69 years old, hypertensive male, hemodynamically stable, presented with complaint of anterior ST elevated MI with stable hemodynamics. After ACS protocol, the patient was shifted to cath lab. Angiography was performed, which showed that circ non-dominant small total proximal occlusion with RCA dominant normal non-obstructive, and the plan probably was left main to LAD stunting of the culprit vessel. While wiring the lesion to cross the lesion mid-LAD, the BM wire got angled at the septal branch, which was actually the first complication over here. And to overcome that complication, we brought another BM wire over here, twisted along with it, as the wire could not move forward or it could not move back. So we successfully removed the wire from that septal branch. And we wired the LAD again. We pre-dilated the lesion with 2.5 balloons successfully, and the second complication post that was slow flow plus dissection in mid LAD, which was overcome by intracoronary nitrates, which improved, as well as stunting for the dissection, which we can see over here. The second complication post-stunting was that after stunting the LAD with 2.75 drug-eluting stent at 12 ATM, ostium from ostium LMS to LAD overlapping the inlet of the second stent was deployed at 3.5 drug-eluting stent at nominal pressure, and the same balloon was moved forward, played with the same balloon from osteoproximal LMS at 18 ATM. So the second complication post-stunting was no flow plus the patient complaint of chest pain, ST elevations plus pulmonary edema. We gave intracoronary nitrates in the mid-LAD. We delivered nitrates plus verapamil. Agrastate was given, but there was no improvement in this case. And the second thing which we followed was we gave further measures intracoronary adrenaline, TPA 5 milligram bolus, IV furosemide, BiPAP for pulmonary edema, as IABP was prepared for the patient, but the mean arterial pressure was 65 millimeter of mercury, and there was no need for it. And the flow became better from TME0 to TME1, TME2, and we achieved TME2 flow over here. So after that, we actually gave the dye, but we could not see the flow properly, and we expected here that there was a bold dot, which we could see over here, and actually that was the tip of the broken balloon through which we were giving the boluses. That was broken, we used for perfusion. It is the distal tip of the broken balloon. And we labeled it as bluebird because it was not either coming backward, it was actually trying to go forward. And we can see the tip over here. We tried to remove all of the assembly together under supervision, but the guide was disengaging and there was appeared that we would lose the BM wire. So we tried to place another BM wire over here to cross the balloon, and we can actually twist it. But at the ostium of the LMS, the wire was not crossing it, and there was appeared that it may go behind the struts of the stent and it will be distorted. So over here, while we were actually removing, the guide was disengaging and it was still at the tip of the ostium, and another BM was placed. It was hanged in the aorta, and a balloon was taken, which was inflated in nominal pressure, and we tried to remove it. And successfully over here, we can see that with the help of the balloon which was already broken, along with it, it came together. And here it came towards the radial artery. The couple reached the sheath, but over here again it got stuck. It could not move further. So we took 3 wires, 2 wires distal to the balloon, and 1 wire, the floppy part, was wrapped around the balloon. And after careful wiring it and twisting it, it successfully moved out of the radial artery over here. This was the broken part of the balloon, the BM over which the balloon was present, the broken part, and so the conclusion is that complications haven't read the books. If anything can go wrong, it can go wrong, but by provision, you can remove most of the dislodged equipment without using an additional inventory. Persistence and perseverance are important in getting out of tough complications. And my take-home message is, if we actually present cases which are being successful in this form, so it is also essential to bring such cases which are full of complications to present and share the experience with you all. Thank you so much.
Thank you so much. And lastly, we call upon Dr. from Lady Reading Hospital. Dr. Wasim, please. He's from Lady Reading Hospital, Peshawar.
Good morning. I am Dr. Wasim, an intervention cardiology fellow in Reading Hospital, Peshawar. The title of my case was Out of Frying Pan into the Fire. This 14-year-old young boy with known case of aortic stenosis presented to OPD with palpitations and NYHA class 3 dyspnea. He had no significant past history. On examination, he was vitally stable, but heart sound showed ejection systolic murmur on aortic area. Echo was done, which showed a severe aortic stenosis. His BAV was planned by Pete's colleagues, but what happened during the BAV that the IMA catheter was used to cross the aortic valve, that its tip broke off and it snugly fixed into the circumflex. In the meantime, the adult cardiology team was called for help. You can see that the broken tip of the catheter in the proximal segment of the left circumflex. So what we did, we went for a balloon assisted retrieval of this broken piece of catheter. So we wired the lumen of the catheter and we inflated a balloon at low pressure distal to this tip of catheter. And when we were pulling it, what happened is that it flew and went to the distal circulation. We were not sure because initially we thought we were in the lumen of the catheter, but we were outside the lumen of the catheter. So we checked the coronaries, the patient was stable, no active complaints, and the coronaries were fine. So we started our search for this broken tip of catheter. We took this distal aortogram and it was found around this right common iliac artery, but we were taking different shots to localize this broken tip of catheter. We thought that it may be in one of the mesenteric arteries, so we engaged the superior mesenteric artery and it was found that it lies in one of its branches. So we took a C2 catheter. Again, we were trying to cross it to retrieve it through a balloon. We were trying to cross it, but the support of this catheter was not good. Again, we were unable to retrieve it, so we took shots to confirm its location. This time we took a heart rail soft straight tip catheter. We were able to cross the lumen of this broken tip of catheter, and we inflated the balloon at low pressure. We pulled the whole assembly, and this time we were able to retrieve it through femoral sheath. After that, we did, the Pete's colleagues did successful BAV. Patient was fine, asymptomatic. So what we learned from this case was that all the hardware should be handled gently and carefully and should be checked for integrity. Never apply brake to your efforts once you break your inventory. Must have proper knowledge of anatomy and devices and its usage in such a dreadful situation. And have faith in Allah and fight for your patient well-being. Thank you.
Thank you, Dr. Wasim. So with this, we come to the final announcement of cases number 1, 2, 3, 4. Meanwhile, the dates of the next Pakistan Live are being displayed over there. So we're keeping a... So it's going to be on from 25th to 28th of April in Karachi. And Dr. Bashir will talk in detail about that when he comes to the stage. So the announcement of awards. So the fourth award goes to Dr. Jalal Khan from Punjab Institute of Cardiology, Lahore, and his case was Less is More or Face the Music. Dr. Jalal, please come over to the stage, and I would request Dr. Professor Nadeem Rizvi Saab, the past president, to hand him over cash prize of 50,000 Pakistan rupees. The third best case award goes to Dr. Ali Farahif from Armed Forces Institute of Cardiology, and his case was challenging TAVR case. I would request Dr. Sohail Aziz Saab, the President-elect of the Society, to hand him over cash prize of 75,000 Pakistan rupees. The second best case was by Dr. Wasim Khan, out of the frying pan. He is from Lady Reading Hospital, Peshawar. Dr. Wasim. And I will request the President of the Society, Professor Zubair Akram, to come over and give him a cash prize of 1 lakh Pakistan rupees. And the best case of this Pakistan Live 2023 has been awarded to Dr. Usman Zia from Faisalabad Institute of Cardiology. Dr. Usman, please come over to the stage. And I will request Dr. Bashir Hanif to come over and hand him over cash prize of 1.5 lakh Pakistan rupees. He's requesting to invite over Dr. Abdul Razak Mughal, his mentor, to stage to collect the award with him. Please, Dr. Abdul Razak. Dr. Bashir sir, please would you come over to the podium and give your reflection on Pakistan Live 2023. Dr. Bashir Hanif, the course director. Thank you, sir.
Okay, so finally, good afternoon everyone. I think अब मेरी कुछ heartbeat जो है वो normal हो गई है finally. So I think Pakistan Live has come a long way. All of you know, starting from 2015-16 to now. Alhamdulillah, I must say that you have witnessed also, and we have worked hard to make this an international meeting. And every year we try to improve on this. And I think I want to really acknowledge those who have really helped a lot to bring this meeting to this level, including Afsar Raza Saab, Amber, Dr. Zubair Akram, and all the councils, past councils and current council, including our past president Nadeem Rizvi Saab and rest of the council. And obviously, this would not have been possible without the support and help from all of you, because you are integral part of this meeting, and all of you play a very important role. And also, I think the most important thing I feel, which has given this meeting an international standing, is our international faculty. And I think whether it is US, UK, and China, and everywhere, all of them has taken it very positively, and Alhamdulillah, everyone has been really responding positively to be part of this meeting. Not only that, not only international faculty, but even the best of the international societies, whether it is Society of Cardiovascular Angiography Interventions, even people from Europe PCR, from Turkey, from China, and everywhere, they have been here. I really want to name few people from international faculty who has really played a key role and helped us a lot, especially Dr. Umar Goktekan. I don't know if he's here or he just moved out.
But he has always been very supportive and has been always tried his best. He's currently having his own meeting in Turkey, but he left that meeting and came over here to be part of our meeting. So I really want to give a big hand to him, and grateful to him also. Dr. Chen, he also again almost every year he has been coming here. Faculty from Sky has been coming here, and people from UK and US like Dr. Naeem Tahir Khili, Dr. Javed, and rest of the faculty. I think all of them has been very supportive and very helpful. These people who are here earlier, it's like 2 a.m. At night over there, but they still were sitting there and basically being part of it. So Dr. Umar Goktakan is here again. I want to give a big hand to him once again. Thank you so much for being here every year and helping us and supporting us. It would not have been possible without your support, and I'm very grateful for that. So I think, as I said earlier, every year we try our best to improve. This year you have seen that we had added a few more things, like we had a research session, and surprisingly, even Dr. Abdul Hakim and other people were surprised to see the attendance over there. The hall was almost full in the research meeting. Then we had added the structural heart program. Gradually we are growing the structural programs, and hopefully that is going to be very helpful to all of you. A lot of these workshops and learning sessions has been very popular. Actually, the reason we had less attendance in these halls because everyone was actually interested in seeing those learning sessions and those workshops. So I think next year we are planning to have those workshops and learning sessions as pre-conference things instead of the conference, because a lot of them wanted to attend these sessions and wanted to attend those workshops and learning sessions also. So next year we are planning that we'll be doing it earlier, maybe a day before the actual conference. We'll discuss and do that. And similarly, we also had an excellent session, which I would recommend everyone that you should go back, and once our this whole meeting will be inshallah available on the website, Pakistan Society of Interventional Cardiology website, all the recording of talks. We will try to put the presentations in PDF form, as well as the cases and everything. One session which was unfortunately less attended was the Sky quality in the cath lab session. It was like outstanding. It was all faculty from US, from Sky, and it was amazing. Like I learned so much being in that session, so I would recommend everyone that when it is available, all of you should see that. There are a lot of things like how to do the work-life balance, how to prevent burnout in the cath lab, how you can have your cath lab staff happy and make sure you are doing the right things. So all those things are, I think, in our lives, which is very busy, are very, very important, and all of you should try to see that. Similarly, we have a lot of international cases. We are trying to improve the quality of international transmissions. It's not our fault. Actually, most of the faults has been on the other side. It depends on what kind of camera they are using. We have been sitting and having several meetings to see where the problem lies. But I would say 80–90% problem lies on the other side. You have seen when it was like the case from UK and the case from New York and Singapore, they were outstanding. There was no problem with that. But the cases from other places had issues. So we are inshallah going to fix those issues next year. And we'll be seeing you and looking forward next year in Karachi. You have seen the dates. So that's why previously it took us a while to decide the dates. So this year we decided that every year, last week of April, we'll be doing it so everyone knows this is a meeting instead of changing. Previously, because of the issues with COVID and Zoom and all those things, we kept changing from one to the other. But from now on, it will be a recurring feature last week of April, wherever we go in the future. Now, lastly, I would like to ask everyone for any kind of suggestions, positive or negative feedback. We will try to see if we can put it on the website for your feedbacks so that we can incorporate those feedback and try to improve on that. One particular request to everyone, we want to involve everyone, all of you. But you see, it is very important that if we make, you see, to bring this kind of academic program for so many days and trying to involve everyone and make sure they don't clash with each other, it's a lot of effort. Believe me, I think course directors all of us, including some council members, we were up all nights throughout Ramadan, from night till Dr. Zubair would finish his clinic at 10 p.m. and then we would sit at 10 p.m. and we were up till Sari to go over this throughout the Ramadan and even before that. So it takes a lot of effort to do that, to make sure we involve everyone, make sure they are able to contribute and be here. But unfortunately, what we have seen, and at least it's more in this meeting, that those people who were in as chairpersons or those who were, even some of them who were presenting, when I called them on the stage, nobody was here. So we have made a note of this thing this year, and we will, in the future, not involve those people who don't take this seriously. We want to involve, but for involvement, you have to have some little bit passion and time commitment also. It's just not, I know I get calls from everyone that please involve us, but I think if I involve them and then they don't show up when they are needed, that really looks bad. Like international faculty is sitting there at 2 a.m. and our people who are maybe walking outside, I've seen that, and not really taken it seriously to be here. So I would request that if we involve in the future, I think we'll make sure beforehand, if anyone commits that they are coming and they want to be involved, they have to be here. That's going to be my request to all of you. And as I said, suggestions will be more than welcome in the future, and we will keep working hard, try to improve. I want to acknowledge all other my course directors who have worked hard with me, Dr. Tahir Saghir, Dr. Zubair Akram, and special thanks to really Arslan, who have worked very hard in terms of developing the app, website, and making sure that all those things gel together and we are able to come up with this kind of a program. And lastly, thank to the council members previously who has been here, all of you who have been contributing by international faculty, international studies, and everyone. Hope to see you all next year, inshallah, in Karachi in last week of April. We'll be there to welcome you. Thank you.
So next up, I would request Professor Zubair Akram, the President of PSIC, to come up and address. Professor Zubair Akram.
Bismillahirrahmanirrahim. Thank you very much, Arslan. First of all, welcome to the new Council 2023-2025. I think we should give them a round of applause. Most welcome to our new President-elect, General Suhail Aziz, very deservedly there. So we are so proud of you, you know. May I request Dr. Godkin to please come on the front seats so that we can feel your presence and acknowledge your contributions, Dr. Godkin. So then I'd like to welcome Dr. Suhail Salimi also. He is coming from south of Punjab, Chaudhry Parvez Rai Institute of Cardiology, and he is there as one of the council members for this Park Live. So just to recap, you know, it was an uphill task, you know, especially with Ramadan just before the meeting, you know, and a bit of an economic crunch which the country is facing, you know. And we were so doubtful at times what will be happening, you know, especially with the economic crunch. But I must say, I am so proud of all the council members, the course directors, that they have put up a wonderful show. And, you know, in this very meeting, you know, you have seen we have made a lot of new changes, you know. Adult congenital is back. Stroke sessions were there. Then there were, you know, electrophysiological interventions also coming. And there were overwhelming response for this hands-on training workshops with simulators and equipment, actually. And all the halls were jam-packed. We had 11 live transmissions from overseas. And then, you know, there were live transmissions from local centers from Punjab Institute of Cardiology at Berry International Hospital. My special thanks to our overseas faculty who were online and physically present, you know. My special thanks to Dr. Chen from China and especially Dr. Omar Godkin. He deserves a nice round of applause. As Bashir has told, there is a Turkish meeting going on. He flew specially last night just for the meeting, and he was in the conference hall, then doing the live cases and all that. It's not just for this year. He has been a regular feature of Pakistan Live since so many years. He was there in Karachi, he was there at Islamabad also. So proud of you, sir, and so proud of your team, We acknowledge so much of your contribution, As president-elect, initially and now the president of the society, obviously taking advantage of your opportunity, I made them the promise, that we'll be going to all the worthy cardiology community of Pakistan, that we will be going with international collaborations with all other societies and friends like the Turkish group. And I'll strongly request you, me and Bashir and all the council members will constantly in contact with you, and we would like to have exchange program with your institute if you allow. So I think that would be a great contribution. There have been people at your center, I think, who have learned a lot, and obviously going there, seeing there happening, especially all sorts of structural interventions especially, it will be great. So regarding, I must acknowledge I left it for the closing ceremony, the contribution the course directors have made, Dr. Tahir Saghir, you were wonderful, and me, obviously, because of some reasons, Amber had to withdraw, and I was made the course director, so I was doing the dual duty of being a president-elect and running the council affairs along with course directors, which I tried my best. I don't know whether I succeeded or not. But the most important comment I want to make is one of the best things that happened over last decade to Pakistan Society of Interventional Cardiology and Cardiology community, one of the best is Dr. Bashir Hanif. And round of applause for Dr. Bashir Hanif. So, you saw in each sessions, there were about 8 to 9 moderators here, and you could see 10 to 15 overseas, whether it's US, UK, whether it's Southeast Asian countries or the Gulf countries. And the most difficult task, what he was telling about, that we worked till Seri, how to coordinate with the American US people, In the East Coast, we are 12 hours ahead, and for West Coast. And from the East Coast, we were at 9 hours. So we are really thankful to the overseas colleagues there, One of the senior most, the CTO experts, world leaders, and from Italy, for Europe, everywhere, especially the US people who would sit late night there to be among the panelist list or early in the morning for the panelist list. And once again, as acknowledged by Dr. Bashir Hanif, one of the very silent character sitting on my right side, he has been the very, very silent member of our course directors team. He is the associate course director, a wonderful, upcoming, the youngest professor of cardiology in Punjab, Dr. Aslan Masood. He also deserves a round of applause. Not only he worked day and night, for us, but also you saw that Park Live app. It's as good as any international app. Always, you got the live transmission going on. You had your personal calendar, you had audience interaction, etc. So, it was his effort, and we salute you. So, rest of all, just to coming to the pharma industry, without the contribution of the pharma industry, we couldn't have been able to hold it. And thank you very much for all the pharma people sitting here. And finally, thank you very much all the senior faculty of cardiology on Pakistan, all my colleagues, friends, students, everybody who has been here to make Pakistan Live 23 a success. Thank you very much.
Aslan, can I just have 1 minute, quick? I wanted to request everyone for the cases, the interesting cases. In the future, I think the best is as soon as you have any case which is you think is interesting, which you can send to the Park Live instead of waiting till the last. We are going to come up with something on the website so that you can actually send the case right away and say this we are sending it for Pakistan Live 2024, and we can keep those cases like till the end, and then we can evaluate and see which is the best. And in the future, this year we couldn't do it. There were some limitations. But in the future, we will be sending people to US. Last year, we were able to send to the Sky Fellows course to the best case winner. And similarly, in the past, we had sent to C3 and other conferences like in Turkey and other places. So in the future, we'll be doing that. So this should be a great incentive for all of you to do that. Lastly, I really want to thank Orbit's team. They have really worked very hard day and night. I know there are some shortcomings, all of us have that, but most of the time, I think it's a human nature that we forget the 95% of the things which are done right, but those 5% which are not done right, we keep really hammering them, and we have been after them all the time that this is wrong, this is wrong. But they have overall done a phenomenal job and brought this meeting to this level. And I really want to thank Zohaib, our IT person, Uwais, the CEO, and Maria has been working with us day and night, and the rest of their team. Give a big round of applause to them. Thank you so much for all your help to make this conference successful.
Okay. So the portal for submission for the next Pakistan Live will start in a few days, and we'll announce it in the groups. It will be available all year round. And another thing, we have added a new feature on the website, PSIC Community Search. You guys can go over there and search your name and your colleagues' names, and you will find their pictures, email address, and the institute they are working. So in the end, to conclude the session, I will request Dr. Tahir Saghir Saab to give his vote of thanks.
Dr. Tariq Ashraf has a request to everyone, being the editor of the journal. It has come a long way. We all again request from the council that all of you, now it is accepted to CPSP also, so your HEC also, so you should be sending your articles, review articles, cases or anything to the journal so that we can take the journal to the next level, please.
Thank you, Aslam. Assalamu alaikum. My life is made easy by thanking all of them, by our worthy council members. But as a part of a routine, I would now like to thank especially our overseas faculty online, and also the overseas faculty that have attended our conference, that is Professor Godkin, Professor Chen, and Dr. Salman Arai. They are physically present here and involved in our live cases along with the sessions. I would also like to thank